The drug action of Parkinson's disease will be covered across two different videos. The first video will focus on the gold standard or mainstay of Parkinson's disease therapy, dopamine replacement with levodopa and dopamine agonists. These drugs are used as monotherapy or sometimes in combination for the treatment of Parkinson's disease. The second video will focus on other categories of therapeutics used to treat Parkinson's disease, including monoamine oxidase B inhibitors, catechol O methyltransferase inhibitors, and antimuscarinic drugs. First, let's talk about the gold standard of Parkinson's disease therapy, which is dopamine replacement. As we know from the pathophysiology of the disease, the movement dysfunction is caused by a loss of striatal dopamine release following degeneration of nigrostriatal neurons. This loss of dopamine release in the striatum directly leads to the motor signs and symptoms that we identify as being characteristic of Parkinson's disease. Therefore, dopamine replacement therapy aims to remedy the motor dysfunction by directly replacing the dopamine that has been lost due to nigrostriatal degeneration. The graphic on this slide will be shown multiple times as we discuss the different drug classes used in the treatment of Parkinson's disease. First, we'll focus on dopamine replacement. The mechanism of dopamine replacement therapy is that it simply replaces lost dopamine due to nigrostriatal degeneration. However, the inherent problem with replacing dopamine directly is that dopamine itself does not cross the blood-brain barrier. Dopamine given orally has many peripheral effects on the body, most of them unwanted effects, but it does not cross the blood-brain barrier to be able to distribute to the site where it is needed in the striatum. Therefore, the solution to this problem is to administer the immediate metabolic precursor of dopamine, L-DOPA, or levodopa for short. You may also hear it called levodopa. Both are correct. Levodopa is the immediate precursor of dopamine, and it is able to cross the blood-brain barrier. As shown in this image, L-DOPA, when administered orally, gets into the bloodstream, enters the circulation in the brain where it crosses the blood-brain barrier, enters dopaminergic neurons where it is converted to the neurotransmitter dopamine, and can replace lost dopamine due to nigrostriatal degeneration. One other important thing to note about L-DOPA or levodopa is that it is also the metabolic precursor of norepinephrine. This is especially relevant for some of the side effects that we will talk about. So keep in mind that L-DOPA can be converted to both dopamine and norepinephrine in the periphery as well as in the central nervous system. One other quick note here, you may hear me use the terms L-DOPA and levodopa interchangeably, and keep in mind that these are both referring to the same chemical entity, which is the L enantiomer of the DOPA metabolic precursor to dopamine. The schematic shown here depicts how L-DOPA is converted to dopamine and subsequently to norepinephrine. The amino acid dopa decarboxylase, which is also known as aromatic L-amino acid decarboxylase, converts L-DOPA to dopamine in dopaminergic neurons. In adrenergic neurons, dopamine can then be further converted by dopamine beta hydroxylase to norepinephrine. When L-DOPA is administered alone orally, it is rapidly absorbed into the circulation. Because it is an amino acid-like, its absorption is delayed by food, and therefore absorption is decreased when given with a meal and increased when given just prior to a meal. The plasma half-life of L-DOPA on its own is about 1 to 3 hours, and metabolites of L-DOPA, which are also metabolites of dopamine and norepinephrine, appear in the urine within 8 hours of a single dose. Unfortunately, when L-DOPA is given alone, only about 1 to 3% of the dose enters the brain. The reason for this is that the vast majority of L-DOPA, 97 to 99%, is metabolized peripherally before L-DOPA ever has an opportunity to cross the blood-brain barrier. This results in significant conversion to dopamine and norepinephrine in peripheral tissues and significant peripheral side effects. Therefore, L-DOPA, when given alone, requires very large doses to get a large enough concentration of L-DOPA in the central nervous system or the brain. This also results in a significant number of side effects. When L-DOPA was first introduced, it was a miracle drug and could remedy the motor dysfunction in Parkinson's disease. But because only a small percentage of the dose enters the brain, patients were forced to take very large doses and experienced significant cardiovascular side effects. However, there is a solution to this problem of the low amount of L-DOPA entering the brain, which we will talk about in the following information. The solution to the problem of only a small percentage of L-DOPA entering the brain is to co-administer L-DOPA with a drug that blocks its peripheral metabolism. And that drug is Carbidopa. Carbidopa is an inhibitor of the enzyme dopa decarboxylase. However, because of its structure, Carbidopa is not able to cross the blood-brain barrier. Therefore, its main function is to decrease the peripheral metabolism of L-DOPA only. By decreasing peripheral metabolism of L-DOPA, you get higher plasma levels and longer plasma half-life of L-DOPA, as well as increased entry of L-DOPA into the brain. The advent of Carbidopa allowed decrease in the daily L-DOPA dose by over 75%. This significantly reduced the number of side effects associated with taking the L-DOPA-Carbidopa combination. The graphic on this slide depicts what happens when L-DOPA is given alone compared to when it is given with Carbidopa. Out of 100% of an L-DOPA dose, 70% is metabolized in the GI tract and does not even make it into the bloodstream. Of the 30% that enters the bloodstream, 27 to 29% is metabolized in peripheral tissues, leading to toxic effects that are primarily cardiovascular in nature due to conversion to norepinephrine. Finally, about 1 to 3% of the dose enters the brain. In contrast, when given with Carbidopa, only about 40% of the L-DOPA dose is metabolized in the GI tract. Of the 60% that enters the bloodstream, about 50% is metabolized in peripheral tissues, which can lead to some side effects that we will discuss momentarily. However, in this case, 10% of the original dose is able to enter the brain by crossing the blood-brain barrier. This is a tenfold increase in the concentration of L-DOPA in the brain. And this is what results in a significant decrease in the daily required L-DOPA dose when given in combination with Carbidopa. Therefore, it is the combination of Carbidopa, L-DOPA that is the gold standard for Parkinson's disease treatment. One of the primary proprietary products of this combination is Sinemet, so you may also hear the term Sinemet used to refer to the combination of Carbidopa-Levodopa. As discussed previously, the presence of other amino acids can decrease the absorption of L-DOPA. And so L-DOPA should be taken just before meals when there are no other proteins being absorbed. The Carbidopa-Levodopa combination is available in several different formulations. For example, a 4-to-1 or a 10-to-1 combination of L-DOPA to Carbidopa. But you will always see more L-DOPA than Carbidopa in the dosing. There are both immediate and controlled release formulations. Some of the brand names are Sinemet or Rytary, as well as recently an intraduodenal infusion, as well as an intranasal spray formulation of carbidopa-levodopa. The best results with this drug are seen early on in the disease course. Although this drug combination has been described as a miracle drug in terms of improving motor function, realistically, the best way to think about this is that it is a symptomatic treatment. It unfortunately does not stop or slow progression of the disease process, and therefore, as more and more nigrostriatal neurons die, the drug works less and less well over time. Early in Parkinson's disease, the drug is very effective, having an onset of effect within about an hour, and keeping patients within the clinical effect window for anywhere between 6 to 8 hours. So there's a long duration motor response and a low incidence of side effects. Of all the motor dysfunctions that occur in Parkinson's disease, Carbidopa-L-Dopa combination is most effective against bradykinesia, but does have some activity against the other motor features, such as tremor and muscle rigidity. There are four main categories of adverse effects of the Carbidopa-L-Dopa combination. The first are side effects that are due to peripheral conversion of L-Dopa, primarily to norepinephrine, but also to some extent to dopamine. This peripheral conversion is reduced by carbidopa, but not eliminated completely, and therefore there are still some peripheral norepinephrine and dopamine-related side effects. These include nausea and vomiting, tachycardia, orthostatic hypotension, and significant pupil dilation, which can be an issue in patients with glaucoma. Other side effects can be classified as psychiatric effects, and these include things like depression, anxiety, and hallucinations, which can all be increased by carbidopa-levodopa because increasing dopamine in other parts of the brain is associated with some of these effects. The last two groups of adverse effects, dyskinesias and response fluctuations, we'll talk about in more detail on the next slide. Dyskinesias are abnormal involuntary movements of the face and distal extremities. It can be very distracting and problematic for patients as well. Patients who have been on L-Dopa for several years will begin to develop dyskinesias, and 80% of patients who have been on L-Dopa for 10 or more years will eventually develop this effect. It is related to dose, so the higher the dose of L-Dopa and the more frequently L-Dopa is taken, the more likely dyskinesias are to occur, but there is some interpatient variability, with a subset of patients never developing dyskinesias to L-Dopa. At the end of this section, I invite you to review a video that describes dyskinesias and how they can be very problematic for patients, and in some cases, even more problematic than the Parkinson's motor dysfunction itself. One of the things to think about dyskinesias is if you've ever seen an interview or a video with Michael J. Fox, and he has suffered from Parkinson's disease for many years, many of the abnormal involuntary movements that he does during these interviews are actually dyskinesias that are the result of the L-Dopa medication, not the underlying Parkinson's symptoms. L-Dopa use over a long period of time is also associated with other response fluctuations. These response fluctuations occur more frequently as the treatment continues over time. The first response fluctuation I will mention is called the wearing off phenomenon, also known as end of dose akinesia. What tends to happen over time is that instead of a gradual decrease in motor function, as would normally be seen early on in the disease process, in moderate to advanced Parkinson's disease, the wearing off or end of dose decrease in motor function happens very sharply and rapidly. So sharply and rapidly, in fact, that some patients may go from motor activity to completely akinetic, which means they're completely immobile over the period of several minutes to about an hour. The best way to prevent this is to take the doses of L-Dopa more frequently. but there is also a rescue medication that is available to rescue severe akinesia. We'll talk about that drug a little bit later when we discuss dopamine agonists. The other response fluctuation I will talk about is the on-off phenomenon. Before I talk about that, let me orient you to this graphic a little bit more. In Parkinson's disease, there is a threshold or dose above which you will see a clinical effect in patients. Going beyond that response threshold too far results in dyskinesias. And the goal is to keep patients within the appropriate clinical effect window, above the response threshold, but below the dyskinesia threshold. As we saw earlier, in early Parkinson's disease, this is fairly simple to accomplish with a single dose of carbidopa-L-dopa. However, as the disease advances to moderate and advanced Parkinson's disease, a single dose of L-dopa is no longer able to provide a significant duration of motor response. You start to see a much shorter duration of motor response. And in addition, the motor response could actually surpass the dyskinesia threshold, resulting in significant dyskinesias. This begins to be observed in moderate Parkinson's disease, but is very prominent in advanced disease states. The on-off phenomenon is a situation in which there are alternating periods of akinesia. Those are considered the off periods when the patients are essentially immobile. And these alternate with periods of mobility where the patient is able to move around but is significantly dyskinetic and exhibits many dyskinesias. And this is considered the on period. The on-off phenomenon is best evidenced by the graphic on the right side of the screen, where you can see the patient is spending more of their time either off or on than they are spending in the clinical effect window. And this can be a problem for many individuals. Unfortunately, these fluctuations occur in patients who responded very well initially to their L-dopa medication. And so patients who respond well initially will likely develop one of these response fluctuations over time. The next group of agents for Parkinson's disease I will talk about are the dopamine agonists. These drugs can be used as monotherapy, just like L-dopa, but can also be used in combination with other Parkinson's disease therapeutics. And Dr. Vergukis will get into more detail about those different combinations when she discusses the therapeutics of Parkinson's disease. Dopamine receptors are a family of G protein coupled receptors that are divided into 5 types, D1 through D5. Those 5 types are then further subdivided into 2 main families. The D1 family, or D1-like dopamine receptors, include both D1 and D5. And then D2 family, or D2-like dopamine receptors, include D2, D3, and D4. These receptors are directly activated on the postsynaptic membrane by dopamine, and they also can be directly activated by synthetic dopamine agonist medications. These are drugs that are direct, strong, and full agonists of dopamine receptors of varying selectivities and can be very effective for the treatment of Parkinson's disease because they directly stimulate dopamine receptors in the absence of dopamine. There are some older agents like bromocriptine and pergolide you may see referred to or referenced, but these drugs are very non-selective for all dopamine receptors as well as other neurotransmitter receptors, and they're rarely used anymore because of their more significant side effects. The newer agents, the ones I will talk about today, are more selective, but have the added issue of causing some impulse control disorders in about 15 to 25% of patients. Shown on the slide here is the structure of a dopamine agonist drug, apomorphine, as well as the structure of dopamine itself. As you can see, the chemistry of the dopamine agonist apomorphine somewhat mimics that of dopamine. The tertiary amine, or the nitrogen with 3 bonds, is important for anchoring the molecule to dopamine receptors. And in most dopamine agonists, you will find this tertiary amine structure. Most dopamine agonists also contain the structure of dopamine within some larger structural group in an extended trans conformation, as outlined here. All of the agents that we will talk about exert their pharmacologic effects through D2 family receptors. Some are non-selective for all dopamine receptors, and some are selective for the D2 family primarily, but for the most part, it is thought that D2 agonist activity is responsible for the beneficial effects of these drugs. Now I will talk about 4 specific dopamine agonists. The first is pramipexole or Mirapex. Pramipexole is considered a non-selective D2 family agonist, meaning it non-selectively activates all members of the D2 family. Its metabolism is negligible and it is actually excreted unchanged in the urine, and therefore could be a good option for individuals who have either liver or kidney issues. The next drug is ropinirole or Requip. Ropinirole is relatively selective for the dopamine D2 receptor. So I consider ropinirole a D2 receptor agonist. It is metabolized by N-dealkylation through the CYP enzyme CYP1A2. This is important because CYP1A2 is induced in smokers, and therefore the AUC or the blood concentration of ropinirole is reduced by about 30% in smokers, and the dose may need to be adjusted in those individuals. Next is rotigotine or Nupro. Rotigotine is a lot like pramipexole. It is a non-selective D2 family dopamine agonist, activating all D2 family members relatively non-selectively. The thing that makes it different from the first 2 agents we talked about is that it is available as a transdermal patch applied daily. This can result in possible application site reactions, which is not true of the other agents, pramipexole and ropinirole, which are administered orally. Rotigotine is N-dealkylated by CYP2C19 and therefore can have some concerns around polymorphisms and drug-drug interactions that should be carefully examined. The last dopamine agonist I will talk about is apomorphine or apokine. Apomorphine is non-selective dopamine agonist for all dopamine receptors, D1-like and D2-like. Apomorphine is used in special instances to rescue off periods of akinesia using a subcutaneous autoinjector. The reason it's useful in this instance is because the benefit will start to be seen within 10 minutes and can persist up to 2 hours. So this is helpful in individuals who experience significant wearing off, also called end-of-dose akinesia, or who have issues with the on-off phenomenon. Given its non-selectivity, there are significant side effects due to peripheral activity that include nausea and vomiting, hypotension, as well as the possibility of causing dyskinesia when dosing is too frequent. The adverse effects of the dopamine agonist can be divided into GI effects, cardiovascular, psychiatric, and neurologic. The GI effects are primarily nausea and vomiting, which can be reduced when these drugs are taken along with a meal, constipation, dyspepsia, reflux disease, and some GI bleeding. Cardiovascular effects include orthostatic hypotension, the possibility of causing an arrhythmia, not in all patients, but when arrhythmia is identified, the drug should be discontinued, as well as the possibility of causing some peripheral edema. Psychiatric effects include some confusion, hallucinations, as well as the compulsive behavior that I mentioned earlier. And compulsive behavior in this case can look like other typical compulsive behaviors, including gambling, shopping, spending money, eating, but can also take some other forms as well. I remember reading a case study at one point about a patient on a dopamine agonist who compulsively nailed nails into all the door frames and trim in their house. So it can really take many forms. The neurologic effects include dyskinesias.
And narcolepsy is possible as a side effect as well. In thinking about these side effects of dopaminergic medications, now might be a good time to review the dopamine pathways that we discussed in the schizophrenia and antipsychotics sections of the previous semester. And think about why the psychiatric effects of confusion, hallucinations, and compulsive addictive behavior would be relevant to increasing dopamine receptor activation with a dopamine agonist. What brain pathways are involved? What is the mechanism that's going on that could lead to these psychiatric side effects? Some review here would probably be useful.
At this point, it's a good time to review some of what we just discussed. Using the QR code on the screen, you can directly link to a video that approaches dyskinesias from a patient perspective. This would be a really helpful video to watch that introduces you to a patient with Parkinson's disease, their treatment journey, as well as the development of dyskinesias and how this affected them directly. It's about 7 minutes long, and I encourage all of you to watch it.